This is going to be a presentation on HIV and AIDS. There's a big significance when we talk about HIV and AIDS. I think that the most current and updated information is on the cdc.gov website. I think that it is valuable to go and look at that website to see exactly what it says. Globally, right now, 40 million people are living with the HIV virus. Once you get this virus, it's nothing that you can get rid of. You're going to live your life or die with this virus. It's nothing that's going to go away at this time. In the United States, we have approximately 810,000 cases of AIDS diagnosed. And I think the CDC website, they quote that 50,000 people will be diagnosed this year with an HIV diagnosis. You can see here that the AIDS-related deaths are significant, and I think it's important for me to point out that greater than 10% of these people are going to be over 50 years old. With people getting divorced or with older people actually having a sexual life that goes far beyond their years. These are the people who never thought that they were going to have to worry about pregnancy. However, they are the ones that definitely have to worry about catching this virus and living with this. Transmission of HIV, it's a very, very fragile virus, and it can be found in any secretions. Those include blood, semen, vaginal secretions, as well as breast milk, and it can be transmitted through an infected partner, exposure to infected blood or blood products, and again, there is a perinatal transmission, and that would be through pregnancy and breastfeeding. The pathophysiology of HIV, this was something that when I went to nursing school, there was no HIV, there was no AIDS. I can remember that it was a very, very frightening time back in the 1980s when there were cases that were being reported and we really didn't know what to do with them. Again, I think that if we look at what's going on today, we have the Ebola virus. We do have somebody now in the United States that has gotten the Ebola virus or came over with the Ebola virus and is now currently in one of the Texas hospitals in Dallas, as well as the recent news where there was somebody who did not travel over to West Africa but is actually residing in Spain, who is our newest victim of Ebola. Again, it's very, very frightening when we don't have the answers, when we don't know very much about it. I think that there is a panic that sets in. Basically, this is a virus that is going to bind and hook onto the cells, and it is going to involve the CD4 receptor sites. If you remember back when we were talking about the CBC and the differential, under the lymphocytes, there was a further breakdown of B and T cell and non-killer cell. This is going to affect the T cells. This is a graph that I did find, and again, I think that you do have a graph that is in IGI that you can refer to, but this is one that if we were looking at the approximate statistics, and again, it really depends on, where you're getting your information. The information is all going to be slightly different. The only thing that I want to point out here is that right now, currently, there is a higher percentage of men to men who have acquired this disease. Again, I think that it could be because of anal sex and having the colon being so fragile and that the virus can easily enter and penetrate the colon. Again, if we have high-risk heterosexual population, that is going to be our other big number. Again, with the teens who are having sex or their perceived lack of it, Oral sex is considered a high-risk heterosexual behavior, and you can definitely get HIV and AIDS through that. Injection and drug use, that is another population, so that when we have needles and they are shooting up their drugs and then sharing those needles, that is a big potential also. And then that other last one here with the 4%, that's actually men to men with drug use also. So that is another element of this. Basically, the virus is going to enter the cell and it does become part of the cell's genetic structure. All of the daughter cells from the infected cells are considered infectious, and again, it continues to replicate, and it replicates very, very early on when we have a very high load of the virus. Actually, probably the highest load of the virus is in the very initial beginning when all of the cells are getting infected. For the initial infection, this basically, according to the CDC's website, it generally will occur about 2 to 4 weeks after the encounter, or when the body actually has the HIV or AIDS virus penetrate within. Again, it's called viremia. Viremia, there really is very large amounts of virus in the blood, and according to the CDC, this again is probably the highest load of the virus that we can see right now. Initially, there may be few clinical symptoms. The only thing is that some people do report acute flu-like symptoms, and the flu-like symptoms can occur, would be fever, sore throat, and lymphadenopathy. So again, many people get the flu and clearly it's not HIV and AIDS. So we have to determine, first of all, whether they have any of the predecessors to getting and acquiring the HIV virus. The CD4 cells are infected, and when they get infected, we are talking about the lymphocytes, the monocytes, macrophages, astrocytes, and the oligodendrocytes. HIV does cause an immune dysfunction. It does destroy the CD4 T cell helper cells, and as it does that, we become very immunocompromised. HIV does destroy 1 billion of these cells every single day, and when we get into problems is when our CD4 T cell count drops below 500. Again, it starts with an acute infection, flu-like symptoms, and then after that initial viremia, it is going to turn into a chronic HIV infection. They can be very asymptomatic for years, and then as their CD4 T cells start dropping, that is when they become very immunocompromised and are in a state to catch all of these different types of infections and have a lot of different problems related to their immunosuppression. Oral hairy leukoplakia is definitely one that is noted at this time. Candida infections, and again, fever, sweats, diarrhea, and headache. Now, I know that there are a lot of people that you have taken care of out on the hospital floors that have Candida infections within their oral cavity. Again, we can't think that every single Candida infection is because of HIV or AIDS. However, I think that what is important is that when we are trying to rule out all of these things to determine what the cause is, this is definitely got to be in your list of possibilities. When people actually develop AIDS, they are going to have a CD4 count of less than 200, or according to other CDC criteria. If they fit any of the other CDC criteria, it doesn't really matter what their actual CD4 count is. It doesn't mean that if it is higher, if they have developed one of these other opportunistic diseases, the CDC considers that they have converted from HIV over to AIDS. Again, I'm going to send you over to the cdc.gov website for further information and what they use as their CDC criteria. Some of the CDC criteria will be Kaposi's sarcoma or Kaposi's. I'm not sure exactly. People say it in different manners. Again, they're going to have like purplish, splotchy patches on their skin. Your Iggy book does have a very, very nice picture in it of a person with Kaposi's sarcoma. Cytomegalovirus virus, we've already talked about that it is in about 80% of the population is cytomegalovirus virus positive. But again, I think that this is going to be a overwhelming problem. Not that they just have the cytomegalovirus virus antibody, but they actually have the full-blown disease. Burkitt's lymphoma, pneumocystis pneumonia. We talk about a AIDS dementia. The patients really are very, very forgetful. They almost look like they are demented. And then we have a problem with the wasting. They start losing a lot of weight and having a lot of diarrhea. Ways that we can test for the HIV virus, it's very, very easy, and I know that they are selling some kits in the pharmacies right now. I think that the best thing is that if they suspect or want to, be promoting their own health, it is important for them to have a screening test done. The first screening test that would be done is called the ELISA test, and if the ELISA test is positive, they will confirm it with the Western blot test. The ELISA is very cheap. The Western blot is definitely a much more involved test. It is a more costly test, but anybody that does test positive for the ELISA does have a confirming Western blot. As far as if they are diagnosed with HIV and AIDS, we're going to continually monitor their CD4 T cells, and again, we're going to look for any signs of immunocompromised people, because again, as they become more immunocompromised, they're going to have a CD4 T cell count that is going to start dropping. Again, when it starts dropping and the number is between 200 and 499, those are people who are going to have significant problems. They do require collaborative care, and the one thing I will tell you is that if somebody comes in and tells you that they are HIV positive, I would tell you to thank them profusely, because they are taking a lot of chance not knowing what your reaction is going to be. So again, if I tell you that I'm HIV positive, I don't know whether or not you're going to go out in the hall and talk to the other nurses. I don't know exactly what your reaction is going to be. It could possibly be that nobody would ever want to come in my room, or that they look at me funny. So again, I think that these people really are taking and giving us this knowledge so that we can be safer, and that our personal health is actually riding on that. So again, thank them profusely for telling you. As far as collaborative care, we are going to watch for disease progression in that immunocompromised host. We are going to initiate antiretroviral therapy. This is going to be a multi-drug therapy that does require taking the pills every single day. They may not want to take the pills, but it is absolutely imperative that if they want to hold the AIDS virus at bay and continue to just have HIV, that it is absolutely essential that they take their prescribed therapy. And again, it's not one pill, two pills, three pills. It's going to be a whole series of pills. Again, we want to prevent and detect any opportunistic infections and treat them as soon as possible. As far as education, we need to educate them about their treatment, about spreading the disease to their loved ones or to other people, and that we really need to work within the family itself so that everybody feels comfortable. Certainly everybody is going to be very fearful. Nobody wants to catch the disease. So it is going to have to be a lot of education based on that. Again, when somebody finds out that they are HIV positive, you can only imagine that, for some it is a real shock. And they just think that it's just not possible. I cannot possibly have the disease. Again, this is a life-altering event, and we do need to help the patients through this and as well their families. As far as our nursing assessment, we're basically going to assess the patients, and depending on whatever stage of disease it is, they're going to need certain types of nursing care. Again, if it is a person who doesn't have the HIV or AIDS, we want to help them prevent from being exposed and having an issue. We need to help with the treatment phase as well as the terminal phase when they're dying of the AIDS virus. There are a lot of social factors here that we're talking about. Again, self-esteem. You can only imagine if you have a drink in a bar, and of course alcohol is definitely a culprit of behaviors that you may not do, but you become uninhibited when you are drinking alcohol. It can be just that one encounter. It could be just that one needle that you share. It could be just whatever the prenatal or perinatal transmission it is. So again, finances are going to be affected. These are going to be people who, may end up having a wonderful job, could definitely lose that job because there is a stigma, whether you think there is or not. And again, people are scared. Persons at risk, again, we have to worry about blood transfusions or blood clotting factors. And again, I think that, people long ago who, the hemophiliacs who received all of the blood transfusions, many of those people are now our HIV or AIDS patients. And it was because they got contaminated blood transfusions. Again, we talked about the shared needles or the syringes, any sexual experience, and sexual transmitted diseases, again, are going to play into this. Again, planning the care. They really need to adhere to their drug regimens. It's not fun to take pills every day, but really, truly, their life is depending on this. We want to promote as healthy of a lifestyle as possible. So again, if these are the drug abusers, obviously we want to try to get them off of the drugs and get them into programs. So again, it's very, very dependent, but again, we should be trying to promote the healthy lifestyle. Get out there and get their pneumonia vaccines, get your flu vaccines, do whatever it is to make yourself healthy. Cut down on the alcohol or eliminate alcohol, and certainly eliminate any of the drugs that maybe they might be addicted to. We want to prevent opportunistic infections, and of course we want to prevent any transmission to others. It really requires very, very supportive relationships. You can only imagine when Magic Johnson announced that he had HIV and AIDS. He was a basketball player who was married or is married, and he did have a sexual encounter. and did develop the HIV virus. That was many, many years ago now, and I can only tell you that Magic Johnson has taken every single one of his antiretroviral therapy pills, or he would not be here today. And then we want to, of course, provide emotional and spirituality support. We want to take care of the holistic person. Again, for drug therapy, that is the treatment at this point. Vaccines are still being experimented with. As far as the health promotion, again, we're going to really work with decreasing the risks related to all of those types of things. For sexual intercourse, of course, there's always abstinence, there's outer course and use of barriers, and use of barriers would be something like condoms and also dental dams. And I know Iggy talks about the use of dental dams in the book. As far as your risk related to your contact with potential sources of HIV and AIDS, I want to assure you that HIV and AIDS is definitely less of a risk than the hepatitis virus. If you're sitting there at the table and you look down and you see a dry blood, that dry blood could be contagious for the hepatitis virus for up to 3 weeks, so approximately 21 days. That same drop of blood, if it is HIV or AIDS contaminated, that really is going to be active for a period of only 3 to 4 hours. So again, you can see that this is a very, very fragile virus, and the bigger thing is, yes, we have to worry about HIV and AIDS, but we have other things to worry about also. Your greatest risk is through any puncture wounds. So again, if you puncture your finger with a needle that has been in a patient, that of course is a great potential. Again, splashing of any blood or bodily fluids, that does happen. It happens with catheters, it happens with JP drains. So again, you want to make sure that you are protecting your eyes against that splash exposure. As far as if you are exposed to any blood, you do need to be seen in the emergency room. If you're working in a hospital, you would go and be seen in the emergency room. They will draw your blood, but I think that the biggest thing that you have to understand is they're drawing your blood to see whether or not you have the HIV virus in you at that point. The HIV virus is not going to show from that needle stick for at least 3 weeks and then going on out from there. So again, we are not going to be able to tell you whether or not you have gotten HIV from that needle stick within that first 3-week period, but we're going to test the patient. If we know where the needle stick and the blood came from, we will test that patient. And if we really think that it is a high risk of contamination, then they will offer you the antiretroviral therapy. If the patient is HIV negative, it really truly is up to you as to whether you are going to take those drugs. However, I think that it appears that most people are holding off. We have to provide testing and counseling. Again, you can only imagine if somebody ends up getting tested for the HIV virus and it does come out positive, they have all kinds of reactions as far as denial, fear, panic.